Thank you very much. Good evening, dear colleagues and friends. On behalf of all executive committee and scientific committee, I would like to welcome our distinguished speaker in this an interesting session and a very attractive one with an eminent speaker. Please, can you show me the first speaker? So I have Dr. Safwan Al-Bayati in a co-moderator for these sessions. Dr. Safwan, he is a fellowship of Royal College physician and surgeon of Glasgow, medical director of New Vision Eye Center, Dubai, phaco-refractive and vitreoretinal surgeon. First speaker, please. So I have a pleasure and honor to introduce Dr. David Chang. He's an MD, clinical professor, Department of Ophthalmology, University of California, San Francisco, USA, adjunct clinical professor, Chinese University, Hong Kong, honorary professor for the Zhongshan, I think, Ophthalmic Center of Sun Yat University in China, editorial board, cataract and refractive surgery today. He's going to talk about IOL scaffold following PCR. Dr. David, please.
Well, thank you very much, and good evening to everyone. And I'm honored to be here. So this is a talk about what to do when there's a posterior capsule rupture and there's nucleus still present. I have no financial interest in this topic. And this is a situation we're talking about. It's a rock hard cataract. We've got all these fragments, but I now have stopped and I'm putting in viscoelastic because there is a posterior capsule rent. So I'm going to try to, first of all, elevate these pieces away and try to get a better view at what's going on. So lots of dispersive viscoelastic here, which will stay in the eye. And you can see that some of the pieces are mobile. I've got to worry about this one. And I have to assume there's vitreous prolapse. So this is where things can go wrong because it's tempting to say, well, I better get those dense pieces out and to continue to phaco. But remember that if you're dealing with a situation with no posterior capsule or barrier in certain areas, when I point the phaco tip posteriorly, I'm not protected. So there's a greater chance of rupturing the hyaloid face, particularly with a downward pointing infusion, and this will cause vitreous to prolapse forward. And as I think I'm going to pluck these pieces, I instead aspirate vitreous with the phaco tip, causing at worst a giant retinal tear and a retinal detachment. So this is the sort of instinct we have to avoid and have discipline to say, look, there must be vitreous. So I've talked about different techniques in the past. One of them is to use the viscoelastic cannula to push vitreous back and then to elevate any pieces upward toward the anterior chamber, where we can isolate them using a technique that I've called the viscoelastic trap. So we know there's probably vitreous, as you see here, but if I can push these pieces up against the cornea or over the iris and fill the anterior chamber with a dispersive viscoelastic that resists aspiration, then I will prevent these pieces from falling back when I do the vitrectomy, because this is the problem. In the absence of the posterior capsule, it's the hyaloid face that supports all the fragments. And when we do our vitrectomy and cut away the vitreous, we lose the support and the pieces drop posteriorly. So what my goal is to leave this viscoelastic alone. And as you can see here, I'm trying to transect and amputate these areas of prolapsed vitreous, and I'm using my vitrectomy handpiece through the pars plana to stay behind the iris and then not remove this viscoelastic in the front of the eye. And then I can deal with these fragments, or if it's a very large nuclear piece, convert to a manual extracap. So let's talk about that right now. So here's the situation I'm dealing with. And I know I cannot chase these pieces. So I'm going to go 3 millimeters back. You can go 3.5. And I'm aiming away from the posterior chamber and more toward midvitreous. Now you see there is a fragment here that is just sort of dangling there. So now I'm levitating it up as shown in the diagram here with the viscoelastic. And I fill the anterior chamber as is shown here, what I call the viscoelastic trap. And now when I go in to do my vitrectomy, this is the phase I'm at. I'm staying behind the iris, sort of behind the level of the posterior capsule, and sweeping along. So I make sure that I amputate any prolapsing strands of vitreous. Look at how the pieces do not move with the circulation, even though I have an anterior infusion cannula, and that's because I've trapped them with the viscoelastic. Now we can address the pieces. So what I'm going to do here is use the IOL scaffold technique. Amar Agrawal has popularized this, but it's nice because I do think I have an intact CCC. So I'm going to put a 3-piece lens in. When I put a 3-piece in the sulcus, I like the Sensar because it's an acrylic material, but the anterior edge is rounded. Unlike the Acrosoft 3-piece, which has a square anterior edge, which can cause iris chafing. So now I'm dialing it into the sulcus. If I wasn't sure about anterior capsule support, I could put it just simply in the angle. I'm going back with my vitrector because, again, I just don't want to aspirate vitreous with a phaco tip. But now this is going to give me an opportunity to remove these pieces and not have everything fall posteriorly, but more importantly, the scaffold prevents vitreous from coming up to the phaco tip. Look at how I sort of position these. It's kind of like setting up bowling pins. I line them up so they're going to be right in front of where the phaco tip is, so I don't have to chase after them within the anterior chamber with the phaco tip. I'm using basically a low vacuum because these are small pieces. But we do need ultrasound to get them out. We do need a phaco tip. And this is ideal for this situation because, of course, trying to get them out manually is difficult when you fragmented it this way. And so very carefully, you can see that I've removed them. Here, I'm kind of running out of space, so I may have to come back and just spend a little more time protecting the cornea, repositioning this piece, lining it up for the phaco tip. But you see now that I keep this from falling back. I also keep shielded. I've shielded my phaco tip from vitreous coming forward. I can go back through the pars plana again, make sure that anything that would be prolapsing forward is removed with a small gauge vitrector. You see there, I might have a strand, it might be cortex, but I can sweep across the incisional area and then make sure my IOL is in good position now that I can see it is in the sulcus. I see the rent across the top. I simply push the optic back and we have capsulorhexis optic capture. So now it won't rotate, it won't decenter. And then I'm using some triamcinolone really at the end as a final check to make sure that there's no remaining vitreous prolapse. And this, along with constricting the pupil, confirms to me that we are in good shape. Again, I can go through the limbus like bimanual INA, but only with the vitrectomy, the small gauge vitrectomy, and I'll close the pars plana sclerotomy with an 8-0 vicryl suture. And there we go. So, this one does have the advantage with pars plana. It's an anterior vitrectomy, but we have the right angle of approach, and we can, again, avoid losing the viscoelastic trap. So I'll end my video there. Thank you very much.
Thank you very much, Dr. David, for this excellent presentation as usual. Is there any question for Dr. David from any of our colleagues here in the panel? Dr. Yuri, or any comments, Dr. Katin Usama, or anyone, Dr. Khalid?
Well, this is a really brilliant technique, which we can see. We keep the control of the last pieces. We try to push to the cornea plane by the viscoelastic. And after that, we try to do the anterior vitrectomy for the pars plana entry. So the idea on the same time to not to push the material down and on the same time remove the vitreous from the anterior chamber. This is the main benefit of the technique what Dr. David tried to introduce.
Okay, is there any other way, I mean, from any other colleagues here, they are doing in another different way, and he think maybe it's more convenient for him? Dr. Rajendra, you are mute. Can you unmute yourself, please?
This was an excellent presentation, super presentation from Dr.
Sealed,
and this definitely works, this IL scaffold. But my question to Dr. David is like, if you have a rent which is larger rent, if you have a larger rent and if you have a larger nuclear pieces lying, because he showed the video where the nuclear pieces were very small. So that could happen towards the end of the emulsification. You are left with few pieces and then the PCR took place. But what happens if the PCR takes place in the beginning? If you had a large pieces of nucleus and the PCR is a bit larger. So in that situation also you'd go for the IL scaffold or some other technique?
Yeah, I'm glad you asked that. So with a large nuclear fragment, or most of the nucleus, so you're better off converting to a manual ECCE, enlarge the incision, and go in with a lens loop, remove the lens there, then you'll have vitreous prolapse to the incision. Possibly you do your normal anterior vitrectomy. So this technique is really ideal for the situation I showed, which also happens frequently enough with smaller fragments. And then, the final thing is really, if the nucleus drops, that's not the worst thing. We have excellent vitreoretinal surgeon colleagues that can safely remove things. I think the point that deserves emphasis is don't aspirate vitreous with a phaco tip, and it's much more preferable to drop the nucleus and let that be cleaned up later. Just do an anterior vitrectomy and close up instead of being too aggressive.
So I just wanted to also I just also wanted to say that sometimes it's nice to do the optic capture before the phaco too. It just provides a little bit better plug there to any further vitreous coming forward. But I think that's an excellent technique. And it really does save you having to, wait till things fall in the back and make a more difficult situation for your retina colleagues. And then I guess the other point is just to be sure that a very thorough peripheral retinal exam is done. Yeah, no, that's all. I thought it was a very elegantly done case, and just those 2 points.
Okay, Dr. David, for whom you advise this technique can be done? I mean, it is something that anyone can use this one, or should be, learn it and know how to do it? Because I don't think that everyone can go ahead directly and do that.
Sure. No, I think whether you're comfortable going through the pars plana, I think it's certainly within the skill set of all of us, because again, it's an anterior vitrectomy, and you don't need to put pars plana infusion in. But I think the principles are, do what you're comfortable with. You have to avoid aspirating vitreous. So it's much better to just, if you're not sure, leave everything alone and not continue with phaco. You can certainly do an anterior vitrectomy, and by using the viscoelastic to move and manipulate pieces, you may be able to, again, avoid things falling. But then you still have that issue of, you've done a vitrectomy, I've got pieces there, now I'm going to go in with my phaco tip and have nothing else to protect me. You have to be so careful that vitreous can prolapse. So I would say that putting in the scaffold is a wonderful technique, but if you're not comfortable with the situation, you're just not sure, obviously you don't want to drop an IOL onto the retina, just leave things alone and let the vitreoretinal surgeon clean it up.
Thank you very much. Thanks a lot.
I have a question to Dr. David, if you allow me.
Okay.
Quick question to Dr. David.
Very fast, please.
Thank you for this very nice presentation. Do you routinely do a retinopexy for these patients as a prophylaxis, argon laser retinopexy for these patients, or it depends on the patient and the symptoms?
Yeah, no, I think that, all of these eyes are at risk for retinal detachment. So as Kathy said, you need to check them peripherally postoperatively, or else have your retina colleague do that. But that's true whether you've done that through the pars plana or not, just PC rupture with vitrectomy. The other thing is, you have a 7-fold increase in the chance of endophthalmitis. So if you don't ordinarily use intracameral antibiotics, I would certainly consider it for these cases.
Thank you very much. We can move to the next speaker. Can you show me, please, team? Next speaker. So we are going to have now Dr. Rajendra Prasad. He is an consultant ophthalmologist, director, senior consultant, anterior and posterior surgeon, RBI Institute, New Delhi, India. And he's going to talk about swing needle microcapsulotomy, new technique to avert Argentina flap sign. Please, Dr. Rajendra. Yes, please.
Screen, okay. Sorry for the delay. Thank you very much, Dr. Mohammed, for the honor you have given us to be here in this beautiful session with the eminent doctors and the panelists. And my topic is saving needle microcapsulotomy, new technique to avert Argentinian plaques and intermittent white cataracts. We have no financial interest in the subject matter of this presentation. Friends, we know that these intermittent white cataracts have always been a challenge to all of us, and the challenge is primarily because of its high intralenticular pressure, which is primarily because of the hyperhydrated fluffy nucleus and the swollen flocculent cortex. And many times these cataracts, they have a thin and fragile capsular bag, so which can be confirmed with the OCT examination. You can see when you look at the OCT images of these cataract, you would see the hyperhydrated swollen lens, multiple fluid pockets, and a very voluminous swollen nucleus. You come across with the shallow anterior chamber, and the most important point is the very tense and stretched out anterior capsule. And what happens, because if you have a situation like this, simply puncturing these capsule of these cataract, the puncture which we create on the anterior capsule start extending and splitting towards the periphery and extend to radially and convert into the complete radial capsular tear. Now, this is what happens with these cataract, and this was described as an Argentinian plaque sign by Daniel Perrones somewhere in 2000, and he said that this is primarily because of the high intralenticular pressure, which is there in these intermittent cataract. And later on came up the concept of the posterior to anterior compartment system. And according to this system, you have a pressurized lenticular compartment system with a high pressure anterior compartment, as well as the propelling and high pressure posterior compartment. So what happens the moment you puncture the anterior capsule, the posterior compartment would push the nucleus forward and hit the back of the anterior capsule. And the tear or the cut which is created on the anterior capsule start opening up and is split into two complete segments and turn up into a radial capsular tear. Now, the various newer innovations took place to neutralize the raised intralenticular pressure, including the phacocapsulotomy, mini-raxis, and so many techniques which came up. And most of these techniques, like one-stage spiral CCC, we keep on doing. Mini-raxis is one of the very commonly used technique to avert the capsular extension of the tear, and two-stage spiral techniques. So I'm not going into the details of these. And then including this small needle aspiration technique to decompress the back, where we use a hypodermic needle to puncture the anterior capsule and then start aspirating the fluid which is there in the intralenticular space. But what happens actually, because whichever technique we use, even before we could initiate the aspiration of the liquid, or even before we could initiate the raxis, the tear which is created on the anterior capsule start extending to the periphery and convert into the radial capsular tear. The incidence reported is around 28.3%. But what is more important in these cases is like up to 7 to 24% of the cases, the tear extended to the posterior capsule and it transformed into the PCT, and which could result us into a serious complication, as Dr. David has just shown. We could have a vitreous loss, lens material drop, or the capsular support loss, so that we couldn't place the intraocular lens into the capsular bag. Now the question arises, why do many of these innovative techniques to neutralize the raised intralenticular pressure do not work? And the problem with the radial extension of the capsular tear continues to be a challenge in intermittent white cataract. It means there has to be some other factor which is very important. So we described a technique which is called as a receiving needle microcapsulotomy to have Argentinian plaque sign. According to this, we found that in reality, it's not the raised intralenticular pressure, the only factor which is responsible for the extension of the tear. It is the configuration of the initial puncture. Like when we open up the anterior capsule to start the capsular axis, or when we push the needle into the anterior capsule for the aspiration. So this is the configuration of the anterior capsular tear which we initiate on the anterior capsule, which is the most important factor for the extension of the capsular tear. And as you can see here, like if you are using the Raxis forceps, sharp forceps, or we are using these hypodermic needle, when you puncture the anterior capsule, we are actually creating a linear cut on the anterior capsule, whether it's a hypodermic needle or the capsular Raxis forceps. Now, this is the kind of the linear cut we produce. And we know that if you create a linear cut and there is a raised intralenticular pressure, and when you open up the capsule, there would be a volcanic eruption of the intralenticular fluid also. And these two factors triggers of a disruptive force along the discontinuous opening of the tear which we have already created on the anterior capsule. And this pressure actually starts opening up the tear because you have a linear cut which has a discontinuous edge, and there is a high intralenticular pressure which would put the pressure on the discontinuous edges, and this discontinuous edges start extending to the periphery and results into a radial capsular tear, which is called as a Argentinian plaque sign. And we also found that this tear always extends along the discontinuous edges. It never extends perpendicular to the linear cut which is created on the anterior capsule. So we came up with an hypothesis that instead of creating a linear cut on the anterior capsule with the hypodermic needle or with the capsular Raxis passage, why not to create a round opening in the anterior capsule for the fluid aspiration or for initiating a capsular Raxis in the beginning. So what we did, we actually developed a device which is called as a sieving needle microcapsulotome. Now this capsulotome has a round and pointed tip, which is similar to the sieving needle, what we use the sieving needle, unlike this, the hypodermic needle. So here the tip is round and pointed. So when you puncture, you can create a hole in the anterior capsule with this device. So we can also use the simple sieving needle also, like which is used for the sieving the clothes. Now this sieving needle, when you can see here, now when you puncture the anterior capsule, you can create a hole in the anterior capsule like this. So this is called as a microcapsulotomy, unlike a linear cut which is produced with the hypodermic needle on the anterior capsule. So there is a difference in the opening, the initial cut which is made on the anterior capsule. So what happens, like when you puncture the anterior capsule of the intumescent cataract with this sieving needle, you create a hole. And the moment you create a hole, you can evacuate the fluid out of the capsular bag. And this evacuation of the fluid from the capsular bag with the help of this needle decompresses the bag and reduces the pressure within the intralenticular space. And once there is a decompression, the capsule becomes relaxed, and then we can start the capsular axis from the point where we created that hole in the capsule. So you can also milk out the fluid, which is there in the intralenticular space through this hole. And once you have completed the evacuation of the fluid, then we can start. We can make a single or multiple punctures on the anterior capsule. So if you have a multiple fluid pockets, then we can use the multiple puncture to evacuate completely the intralenticular space. So this is the video. I'll just show you this. And this intumescent white cataract, absolutely swollen and tense anterior capsule, what we can see here. So you need to stain the anterior capsule and then pressurize the anterior chamber with the viscoelastic. And this is the sieving needle, the simple sieving needle what I am using, and created a hole on the anterior capsule. This is the second case where I'm trying to make a hole. And the moment you make a hole, the fluid would start coming out of the capsular bag. And since this is a hole and it has a circular round edge, so it has a greater resistance against any pressure which is there in the intralenticular space. And then we can evacuate the fluid out of this hole. And once the capsule is relaxed and the lens is depressurized, then we can start the access from that particular point, and we can prevent the extension of the capsulator, because there is a complete relaxed capsule. So you don't have to worry for the extension now, because you can continue the capsular axis in a simple way. So you just complete the capsular axis. So to conclude, the intermittent white cataracts, we know that there is a high intraventricular pressure. And if you use this device which cuts the anterior capsule, whether it is capsular access forceps or the needle, so that should be avoided. And we can use this device to create the hole in the anterior capsule so that we could evacuate the fluid from the capsular bag, and without the fear of extension of the capsular tear. And this device is definitely very safe and very simple. Like, it's one of the simplest device we can use to prevent the Argentinian flag sign in these intermittent white cataract. So thank you very much.
Thank you very much, Dr. Rajendra, for this excellent technique. I think there is many questions from our dear colleagues here. If there is any comment, Dr. Kathleen, so we'll start with you.
Yeah, I love this technique. I think it's really innovative to create a circular hole that's resistant to tearing. It'd be nice if there was an opening there where you could aspirate at the same time. But have you seen any cases where there was extension with that technique, with the sewing needle?
See, actually, the point is because the device, the tip of the device has to be very sharp. That is very, very important. It's blunt. Then when you're puncturing the anterior capsule with that device, if it's not sharp, then it can tear the capsule in other way. It can make a hole which is not circular. But if it is sharp, then you can make a circular hole. So if you have a circular hole, then it will never extend, because it works like a mini axis. Although it's a microcapsular axis, it works like a mini axis because it's circular. So if you have a circular hole, so no these forces cannot rupture. But if it's not circular, then definitely, because in some cases, if you puncture, if you are not able to make the circular hole, then definitely it may extend to the periphery.
And what size sewing needle are you using? What size needle is that you're using?
Needle, we use 19 gauge, actually, because these the device which we have made is a 19 gauge needle, and it doesn't matter much like the size of the needle, but although we have made a 19 gauge, you can use 21 gauge also. But the important point is the tip of the 19 gauge, whether it's a 19 gauge or 18 gauge, the tip would be same. Like, it has to be sharp and pointed tip. So that is the most important thing. The pointed tip, you can make a single hole, you can make multiple holes also in the anterior capsule for the complete evacuation. And it works tremendously very well, because I have not seen any Argentinian flag signs since I'm doing this technique.
Excellent. Dr. David, you have any comment, questions?
Yeah, I enjoyed the presentation. It was very, very nice. Christopher Tang is at Yale, and he has talked about using the phaco tip, and you just kind of immediately do a single pulse into the lens capsule, and it creates a round opening using this exact same principle. So it's the principle that's important. We have a technology in the US called Zepto, and it creates a instantaneous 360-degree hole as well. So all of these, and that is in my hands foolproof for a capsulorhexis in a mature lens. So all of them use the same principle of simultaneously getting some opening with a continuous edge.
Dr. Yuri, can you unmute yourself?
I have just two questions. The first, what about the femto technique for the intermittent cataract case? This is my first question. And what viscoelastic do you prefer to keep the counter pressure in the anterior chamber to compensate high interventricular pressure? This is my question.
See, the idea is to pressurize the anterior chamber. You have to try, do not try to too much flatten the anterior capsule, because if you have a very high pressure in interlenticular pressure, do not try to push too much of the viscoelastic, because that is going to further increase the pressure within the interlenticular space. Because if you are pressurizing a moderate amount of the viscoelastic, you can use viscodispersive, or you can use the cohesive visco also. And but the idea is, do not use too much. You have to use moderate amount of viscoelastic, so that you are slightly pressurizing the anterior chamber. You don't need to pressurize, like as said, like if you are using the mini Raxis, or you're trying to start the capsular axis with the forceps, then definitely you may need to pressurize the anterior chamber with the cohesive viscoelastic. But here in this technique, you don't need to pressurize the anterior chamber too much.
Okay, thank you very much, Dr. Rajendra. Okay, because we are running behind the time, so maybe we can continue at the end of the session if we have the time. Can you show me, please, team for the other speaker, next speaker, please. So now we will have Dr. Khalid Ayyash. He is an ophthalmic surgeon and LASIK specialist, Dar Al Hikma Eye Clinic, Jordan. Dr. Khalid, please, can you start sharing your screen?
Oh, thank you. But I can't share my screen because someone is sharing his screen.
No, no one is sharing.
Thank you for giving me this opportunity to talk. I will be talking about phacoemulsification in the presence of an iris mass. This is a 72-year-old male patient who was presented to me with decreasing vision in his only left eye. The right eye was weak since childhood, and he was planned for left cataract surgery abroad, but his surgery was deferred many times because of the risk of this procedure. He presented with a vision of 3 meters in his left eye with a dense nuclear and posterior subcapsular cataract. And he has a large crescent-shaped avascular, heavily pigmented lesion that is extending from 1 to 5 o'clock, and looks like a mass that is coming from underneath the iris. This is the lesion that the patient presented with, and this patient also brought with him an OCT, images anterior segment OCT, and we can see that there is a dome-shaped mass that is present in his left eye. But we are not sure about the origin or what lesion we are dealing with. This is just a simple cystic lesion? Is this a melanoma? Is this a vascularized lesion? We are not sure about this lesion. When we reviewed the literature, Carol Shield mentioned that there is 6 most common iris lesions that comprehensive ophthalmologists might see, such as a freckle, lich nodules, a nevus, a melanocytoma, a melanocytosis, or a melanoma. But maybe our patient does not fit under any of these lesions. And if you go to a broader differential diagnosis, we can find that this lesion could be a cystic lesion, like a primary iris pigment epithelial cyst, or an iris stromal cyst, or could be a solid lesion, as we already mentioned. So my plan was to consult my colleague, who is an ocular oncologist, Dr. Yaqub Youssef, who is working at King Hussein Cancer Center, so as to better assess this lesion and assess the risk associated with this lesion. And he advised me to see this patient. So I sent him the patient, and he did him a UBM, and we can see how this machine can give us a very good clue and a deep view of this lesion, as we can see in this figure. And we can see that there is also another lesion on the other side of the eye. And if we compare the UBM with the OCT, we can see how much UBM can give us more details and more confident diagnosis of what we are facing with. So this patient has multiple lesions in the iris, and his report came that this is just a simple iris cyst that is extending to the pupillary area with no impact. And there is also a nasal and temporal ciliary body cyst. And he recommended that no biopsy is needed in such a case. And when we reviewed the literature, we find that anterior segment OCT might be more important in small anteriorly located lesions, while the UBM is more or better for imaging large iris lesions with a posterior body, with the posterior extension, as we see with our patient. And also UBM is more important in heavily pigmented lesions as our patients. So the second step was to see what the complication that we could face with such lesions. These patients could have angle closure. His IOP was normal, though they could have a plateau iris syndrome, as our patient has. They could have a pigment dispersion syndrome, corneal edema, cataract, lens subluxation. We should keep this in mind when we plan for surgery. So we decided to do him the surgery. I used a heavy viscoelastic material and staining the capsule. Then when we inject the heavy viscoelastic lesion, we find that this lesion is easily movable, and it gives us space that we can perform the rixes in a good and in a well-centered and a good-sized rixes. And so we proceed with the capsular rixes. And again, once I used a heavy viscoelastic, viscodispersive material, and we can see that the lesion is moving easily under the iris when we push it with the viscoelastic material. So then we start the hydrodissection and doing the phacoemulsification. We can see that this cataract is a large nucleus. It's a dense cataract. So I tried to rotate the lens, but I found it's a little bit difficult. So I didn't want to manipulate too much. So I shifted to a chop technique, and I continued my phacoemulsification in the normal maneuver. Now I'm trying to fracture it into small pieces so I can preserve the cornea and protect the corneal endothelium. Then if we can look at the iris lesion, we can see that how it's floating in the anterior chamber with the fluid inside the eye. And if you watch now, let's keep moving. And now watch to the lesion. Now it comes to the phaco probe, and this will result in the fluids came out of the cyst. But I managed to complete my phacoemulsification in the proper way. I will move forward in the sake of time. Then at the end of the phacoemulsification, and then I do the irrigation aspiration, and I inserted a posterior chamber IOL, and I found that the capsule is intact. There is no area of zonular weakness that was suggested to me. So the second day, the patient has a very good vision, mild corneal edema, and this is the patient's before and after the surgery. So the take-home message is that a preoperative evaluation is a very crucial step in cataract surgery. When in doubt, always consult your colleagues. They can give you a much more idea about these lesions. UBM is a very important tool in such cases, and the proper diagnosis can make the surgery much easier, and do whatever is needed to be done, because these patients are asking for help, and always do the right decision that you feel that you are doing. And thank you.
Thank you very much, Dr. Khalid, for this interesting and nice presenting case. Is there any comments from our colleagues? We have 1 minute, please, because we are running behind the time. Dr. David or Dr. Anindra, Dr. Yuri, anyone?
Sounds like another indication possibly for using the sewing needle to puncture the iris cyst. No, I'm just kidding.
It struck me that maybe the Zeiss intraoperative OCT would be really helpful in these cases. And, you know, I do see sometimes you see something appear behind the iris, especially when I did a lot of ECP, that you didn't even know was there. So having intraoperative OCT, I think, is an additional tool that may help.
Do you think anyone suggests to take a biopsy for this lesion?
The oncology report came. The oncology report came that this is just an cyst, and they were confident of their diagnosis, and so that's why I didn't take any biopsy. And also there was multiple lesions, and the other eye has the same lesion, so the possibility of malignancy was a little bit very low
Okay, thank you very much, Dr. Khalid. It was an excellent case presentation, usually. Thanks. I'll move to the next speaker, please. Okay, we have now Dr. Yuri Takayev. He's an MD, professor of ophthalmology department, Pavlov State Medical University, St. Petersburg in Russia. Dr. Yuri, he will give a talk about Morgagni cataract with PCR. Thank you.
Thank you very much. Thank you for a kind introduction and invitation, Dr. Mohammed. My topic is the Morganian cataract case. I have to say that the fellow eye was operated 10 years ago, but the patient decided to postpone the second surgery, so we have all the calculation for this case. The first eye was done with a multifocal implant, and we are also looking to put the trifocal IOL for this Morganian case, cataract case. So we just start to aspirate the material. And the patient at that moment, she say, oh, I can see the light. So it was very motion surgery after 10 years. And you can see the very fibrotic capsule and weak zonula on the same time. Just create the rhexis in the central area. And you can see that the nucleus is a very small but very rough. This is the 5mm rhexis. Before to start the rhexis, I just put some viscoelastic in the capsular bag just to reestablish the capsule contour. And I start my paper, separate the nucleus for two heminucleus and try to reduce my flow rate. There is no cortex, no material, just floppy capsule and the raw cataract. And at that moment, you can see the zonal problem, which masks the real problem. On the same time, you can see this is the posterior capsule rupture, which I have not recognized on time. I just put the capsule tension ring to support the capsule. Put the capsule tension ring, and I'm still not recognized the problem with the capsule. It's not extended during the step. Just to continue with the ultrasound tip and slowly aspirate the material. It was surprisingly for me at that moment, aspirate some vitreous, and now it's easy to recognize the capsule rupture. Okay, we have a material in front. We have a vitreous in front. And still, we want to put the multifocal implant in the back, so I don't want to put the lens in the sulcus. That is why we put the viscoelastic, just to stabilize the capsule. And I decide to put the vitreous back. And at the same time, I just extend and try to round it, the linear capsule defect, to create the posterior rhexis without vitrectomy. Just enlarge a little bit, and from the other side, by the same manner, I just fix the vitreous and rounded the capsule by the same way. Okay, now we have a elastic posterior capsule opening, and we can start the vitrectomy. I just put some jumps along inside, not at the end, as Dr. David shown us. So I try to paint in the vitreous, enlarge a little bit the main incision and remove the piece before vitrectomy. After that, I stitch the cornea and we start the vitrectomy. And at the end, let's remove the residual fibers. And at the end, we put the lens in the bag. Okay, so platform with the hydrophobic acrylic, and you can see the position is very well centered. We received the 0.3 by decimal on the next day. After 3 months, it was at 20/20. Very good vision outcome. So this is the case. So in some cases, with the posterior capsular rupture, we want not only control the material, we want to avoid to drop the material to the vitreous. At the same time, we want to avoid the traction, and on the same time, we want to keep the capsular bag for the in the back IOL implantation. So it was successfully done in this case. Thank you very much.
Thank you very much, Dr. Yuri, for this excellent case presentation and excellent management as usual. Dr. Yuri, you know, you are the one who teach us and we learn from you a lot. Thanks a lot. And if there is any comment or question to Dr. Yuri about his case, just before that, my question is this one, how old this guy, the patient, if you remember? Because why is the lens is small?
It was a lady. She was not very old. She was 46 years old lady. And she was very strange. She decided that the astrology prognosis for the second eye with the position of the Venus and Mars and Mercury for the surgery is very important. And she postponed for 10 years and came with the Morganian cataract. So this is the case. Time to time it happened from the patient personality.
Well, she got a really good result. She got a really good result. So I'd like to know the name of the astrologer.
Yeah, she picked the right moon phase.
Yeah, we are 100% sure that the astrology prognosis doesn't work because it was really a complicated case.
I did want to make just a comment that I was very impressed with your primary posterior capsulotomy, your conversion to a posterior capsulotomy, because you had so many different forces there. So it's always a little difficult because the posterior capsule is so much thinner. But you had vitreous that could cause some different forces. You had a CTR in there with some zonular weakness. So all the forces could have been slightly different, and you did a beautiful job. It was just a lovely case.
Thank you very much. Thank you.
So I agree, and I'll just add that, you know, the challenge with Morganian cataracts, of course, is doing the capsulotomy, which you did so nicely. But then the phaco, you know, you have this bag that's very floppy. Often the zonules don't stretch the posterior capsule, and so just in the course of phaco, it's very easy to cause a rent. And you know, probably you know, I know you put viscoelastic in, but I think in these cases, you just have to repeatedly re-inject the dispersive viscoelastic in the bag. And what that does is it stretches the bag in the lack of peripheral stretch from the zonules. And You know, that's just one principle to mention.
Thank you.
Dr. Yuri, it was a really excellent presentation, and I had just one small query. Like in your case, the zonular dialysis as well as the PCR took place both together.
Right.
So could have been because you put the CTR before you did the PCC. So putting CTR, if you have a rent in the posterior capsule while putting the CTR, could have extended the rent further. So is it possible like we do the PCC first and then put the CTR?
The problem that I doesn't recognize that with the posterior capsule rupture problem. I put the capsule tension ring because I was 100% sure that the capsule is intact.
Okay.
The zonal problem, focusing my attention at the moment, I lost the real problem at the moment. But you can see it's not extended, the rupture. Maybe the capsular bag was really floppy and the capsule tension ring size was not so big, not stretching too much. So thanks to the Venice and the Mars and Mercury at that moment. I was lucky, not the patient at the moment.
And what were your thoughts about potentially doing a reverse optic capture just because there was so much going on in that eye, just for added stability?
If you lost the capsule and you haven't the opportunity to put lens in there, the optic capture technique is a very, very multifocal implant. The effective lens position is very important to avoid any defocus after surgery. So we want to put the lens in the back. It was one of the main goals.
Thank you very much, Dr. Yuri, and thanks for all panelists. We can move to the next speaker, please. So now is the time for Dr. Kathleen, and she is CMO Eye Health in America. I think this one is less introduction, but Kathleen is a well-known cataract surgeon. So, and she is going to present case of post-traumatic cataract with iridodialysis. Dr. Kathleen.
Thank you so much. And let me share my screen. So I know we have all had these cases. I wanted to present this one in particular because it was a patient who was actually not all that excited about having his iridodialysis corrected. As you can see here, it was from a BB injury 50 years prior. So he had lived his entire life with this never looking right eye and really was not all that excited to have it repaired. And if it was going to extend the surgery at all or have any potential complications, he just wasn't so sure he wanted to do anything about it. I did prevail and talking with him about it. And the day of surgery, he decided, oh, okay, let's go ahead and do that as well. But when you have these iridodialyses, you want to be very suspicious of also having zonular issues in the same quadrant or the same region. So look carefully. Usually you can see actually the margin of the capsule and it may be scalloped, or you may see that there's actually shrinkage of the cataract on that side, a more linear contour, indicating that there isn't good zonular support. So really important to do a complete exam, especially a retinal exam, concentrating on that area as well. There are lots of different options for iridodialysis repair. Some of them have no knots included, like you can see that cobbler's technique, which is the lower right. I think you can see my cursor, so it's right here. There are proline, flange proline solutions as well, which I'm a big fan of, but didn't know anything about those at the time of this particular case. And there have been studies, this was just recently published in 2018, looking at the difference between using a double arm needle technique or a sewing machine technique. So lots of different options in this study. Everything was about the same. They were both very effective. The sewing machine technique, just really quickly, you preload the needle with the suture, and then you can go in and out of the iris, pulling that suture loop as you externalize that. And it just allows you to do it without having to redock suture or needles, versus the double arm needle technique where you do have to dock each needle of the one piece of suture. And that's actually the technique that I'll use for this case. So always these complicated cases, especially if there's iris manipulation, you want to have a retrobulbar block or some sufficient anesthesia. Use slow motion phaco. You know, this is an iris. It's been in that configuration for 50 years. So may not be the healthiest iris. I really want to stay away from that if at all possible. So here's the case. This is the patient. He's had his eye look this way, like I said, for a very long time. But I am going to plan to do a repair of the iridodialysis in this area. There is a little bit of flattening of the contour of the capsule, especially in the area of that cortical change. So I'm very suspicious that there's not 100% complete zonules, but you can see there are zonules there. So that's a little gift. Maybe it's the right moon phase and the right astrology for this patient as well. Who knows? We didn't check that preoperatively. But there is some posterior synechia. We do know this iris is probably very thin or not functioning normally, not looking normal in that margin, just because it's been dislocated for so long. So the first part is just to keep the iris safe. To do that, I'm going to use iris hooks to isolate and sequester the iris away from my phaco probe or my phaco needle. Very gently placing iris hooks sufficiently to keep it out of the way. And since I've distorted the iris a little bit this way, I'm going to really support it in all directions. This patient didn't really dilate excellently anyway. And I'm just trying to make sure I'm keeping the iris as safe as possible. Part of the iridodialysis is actually very near where I need to be working. So I'm going to be extra careful in that area. And then the rest of it, as far as removing the nucleus, is a lot of the same principles that we've been talking about during this entire session, which is you want to keep the anterior segment formed, try not to have any pressure gradients that are not anterior to posterior, go very slowly with slow motion kind of phaco settings, low flow rates. And here we go. This is exactly what everybody has been pointing to, just lots and lots of dispersive viscoelastic. I think, if I had to talk or point to one tool that's most important for complex surgeries, it really is dispersive viscoelastic. The more I have, the safer I feel the surgery is. And sequestering these pieces away from that iris, which is, I really want to make sure I'm not impacting negatively in any way. And also making sure that I'm not dealing with a floppy zonular support in any area. So I'm going to kind of go a little bit forward of here because there's not a lot of excitement that happens, thankfully, during this portion of the procedure. I'm going to just continue these same principles, and I will put a CTR in because I did see that flattening of the margin in the area, although this patient thankfully did have some pretty good zonules there. And you can see that the iris is pretty fragile, even in the areas where I have the iris hooks on the non-injured side. There's some iris atrophy around where that hook has been moving a little bit during surgery. I'm putting in this hydrophilic acrylic lens with these closed loop haptics. Anytime there's a situation where I think there might be future need for fixation, it gives me other fixation options. You can see those haptic loops. You can see the CTR actually through the iridodialysis there as well. I'm going to take out the iris hooks. And now I am actually going to use this cannula as a way of docking the needle from the 10-0 polypropylene suture in order to introduce it through the paracentesis without catching any of the corneal fibers. And I'm trying to be very gentle by also using intraocular forceps when needed so that I'm not impacting this really long-standing atrophic iris. One of the challenges too is with these curved needles, making sure when you're withdrawing it that it's not moving around in a way that also is putting additional traction on the iris. So I'm using a double needle technique. One of the key points about this as well is just being sure that you don't tighten this too tight. You don't really want to cover up trabecular meshwork or really jam the tissue into the angle. And then I'm going to go ahead and place 2 more needles to the right of where I have that double needle as well. So once I get all 4 passes through the peripheral iris placed and then through the sclera, I'll be able to adjust the tension and really look at how this is, how the placement of the margin of the pupil looks, because I want him to have a result that's as natural as possible. These cases are a little bit of artistry and a lot of patience. And as all of these cases are, it's a lot of dispersive viscoelastic. So intraocular forceps are very helpful in gently moving the iris to the right configuration. These knots are going to be buried, but they also should be tied loosely. So there is a gap and the tissue is not covering trabecular meshwork. So I'm going to trim the knot, and then I'll spend a little bit of time making sure that it's rotated well into sclera. You can see now that although there's good approximation as far as where it looks when you're looking straight on the patient, there's actually a gap there. And one of the nice things about having operated for a while is that you get to see these patients years down the road. And so this patient did come back and 5 years after their treatment. So we're going to kind of get to the end here. And we'll be able to see how this looks. But you can see already that's pretty nice cosmetic result compared to where he'd been in the past. And we're going to move forward. So here he is on post-op day 1, not looking great. There's a lot of corneal edema there and some irregular margin to the pupil on the side of the iridodialysis, but he was seeing pretty well. Pressure was good. I didn't have a very sophisticated slit lamp camera here, so this is probably with my phone at the time. And he was using all of his drops appropriately. And this is at a month, really looking pretty good. His vision is great, pressure's great. Here he was pre-op, there he is 5 years post-op. And when he came in initially, I didn't remember that this was the patient. And then on closer examination, I could tell that he had that repair done. And he was very, very grateful that he decided at the last moment to allow me to repair his iris. And there it is on retroillumination. So you can see there's still that little gap. You can actually see his CTR through that gap as well. So again, you want to just be sure at the beginning of these cases that you sequester the iris, use lots of dispersive viscoelastic, use intraocular forceps if available to reposition. Gentle manipulation is important. Lots of different techniques are all successful. Leave that little space. Don't try to make really tight knots. And you can address the decentration or abnormally shaped pupil at the time of that repair. So thank you so much.
Thank you very much, Dr. Catherine, for this excellent presentation. If we have 1 minute or 2, so we can discuss Dr. David, Dr. Khalid, Dr. Rajendra. If there is any comment, Dr. Yuri.
It was a great case. And, you know, these patients, I think this patient's the exception. Usually these patients are so happy, both from the photophobia standpoint and also the cosmetic standpoint, to have a repair done. They're so grateful. It's almost as impressive to them as getting their vision back. So, you know, I would second the suggestion that, you know, kind of learn these techniques and take the time to try to repair the iris.
That's one important. Yes, thank you for this very nice, nicely managed case. And the nice thing that you managed to do is to suture the iris, because after this long period of iridodialysis, these irises usually are fragile, and the suture usually slipped. And sometimes when you do them, after sometimes you find that the iris slipped again from this area, but maybe because you evenly distribute the forces over the entire region of the iris, rather than, as you mentioned, not to make the stitches too tight. This helped to preserve the eye for this long period of time. Very well done. Thank you.
Thank you.
Thank you, Dr. Khalid. Dr. Yuri or another? Dr. Rajendra?
It was an excellent presentation from Dr. Naqvi and beautifully managed, I think. So perfect.
Yeah, brilliant.
Thank you,
Brilliant
Dr. Yuri.
Thank you very much.
At the end, we'd like to thank you all for this excellent, interesting topics and cases presentation and nice discussions. We already 6 minutes over the time, but we have break, so that's why we give a time more. We are lucky that we are having a break after us. Thank you very much, and we hope to see you in the other session soon, inshallah. Thank you very much. And I would like to announce for all attendees that we are going to have a guest honor of speaker after 4 minutes in Hall A only. Please, anywhere, if we are here now in Hall B, so join us in Hall A. Thank you and goodbye. Thank you very much.
Yes, thank you.
Thank you very much.
Bye-bye. Bye-bye. Bye-bye.
Thank you.